the Island Prostate Centre. She's been with us since March of 2017. Her nursing background has been primarily oncology focused since graduating from the North Island College in 2011. Connie began her career in cancer care at St. Joe's Hospital in Comox and spent the first few years as a registered nurse working as much as possible in a variety of settings to gain as much as experience as she could. In 2013, she began her career further by being employed at the Cancer Agency here in Victoria. And she's immersed herself in everything oncology and is loving it, and did love it. During her 5 years there, she also experienced some locum opportunities, and she was able to have experiences in Whitehorse, Guatemala, and Winnipeg, and added to her nursing toolkit in the process. During Connie's first year here at the Island Prostate Centre, she's been a part of a rollout of a provincial prostate cancer supportive care program, and has been an educator and a facilitator for both the sexual rehabilitation and the ADT modules. She's excited to see the message of the symptoms and side effects of ADT getting to patients. Please join me in welcoming Connie.
So, thanks everyone for coming tonight. This is great. I am excited that we've got this very important public service announcement to discuss. It is something, as Bill mentioned, I conduct the same conversation on a monthly basis with the BC Cancer Agency, as well as the sexual rehabilitation module. So there are other modules, and we will speak about them a little bit during this presentation. There's a pamphlet at the back, so if you'd like to know more, grab a pamphlet and run with it, and connect with the facilitator there. So, as you mentioned, I've been working in oncology for a couple years, about going on 6 or 7 years now, and I have worked with a large prostate community and have given a ton of these injections, and this is the first time I've seen any kind of education around the medication, so it's really exciting. We do a ton of chemotherapy teaching, but no hormone therapy teaching, and it's a systemic therapy. It affects the whole body, and it has some consequences, so it's really exciting to be discussing this tonight. And so, more housekeeping considerations. I think most of these have been discussed, but you know, I just want to make sure that you're all aware this is not a medical information session. I'm not giving you advice. If you need to follow up with anything discussed, please see your GP or your urologist or your oncologist. This is very general information. If questions come up throughout the conversation, just pop your hand up, or let me know if you've got something that you'd like to share or a question you'd like addressed, and I'm happy to do my best. I may not have all the answers, but I'll see what I can come up with. And the golden rule: what happens in Vegas stays in Vegas. So because of the nature of this conversation, it is kind of can be sensitive, and if questions or comments come up that are of a sensitive nature, I'd like for them to stay here and not be discussed outside. And if you need to step out, that's totally fine and very understandable. And I'm available afterwards for discussion, as well as signing up for any of these programs. And just a note about the Hot Topics program that we'll be offering. There's a sign-up sheet on the back there. So the first 20 people get a spot, and we'll take a waiting list. So don't all rush at once, but it's there when you want to get there. And the cell phone comment has already been made, so I won't go over that. So tonight's discussion will be all about ADT, but we have to discuss the role of testosterone because it's so fundamental to what we're trying to do here with the androgen deprivation therapy. So we'll discuss that a little bit as well. We'll talk about what it is, why it's used, how it works, and what are some of the side effects, and what can you do to manage those side effects? Because that's probably the most important thing, is how do you be an active participant in managing what hormone therapy can do. So let's talk testosterone. It is the main male androgen, or sex hormone, and it is produced primarily in the testes, a small amount in the adrenal glands, and can also be produced by those prostate cancer cells themselves. So it's important for so many functions in the body, and we'll get into that in further detail in a little bit. So your body needs it, but unfortunately, it is the hormone that drives the progression of this cancer. So it's a tricky thing to navigate. So as you can see, testosterone plays a role in vitally every organ and every system of the body. It helps with with the skin, with its elasticity, with the sebum production, with hair growth, with muscle strength and volume. It's a key player with the male sex organs. Allows for penile growth, the production of new sperm, erectile function, and prostate health. So it's vital there, but in moderation. Also important in development of the bone marrow, primarily red blood cells. In the brain, it affects libido, mood, cognition, affects the heart, the liver, the kidneys, and the bones. And the bones are one thing that are often overlooked with ADT. So we'll discuss that in further detail as well. But it's needed in every area of the body. And it is a bit of a double-edged sword, though, as it is the hormone that drives the progression of prostate cancer. So again, a very important player in this discussion. So how is it produced? Where does it come from? How does this happen? So there's basically 4 main ingredients here. There's the hypothalamus and the pituitary gland, which are in the brain, and they kind of talk to each other, and they signal each other. There's a hormone. It's got a fun name, luteinizing hormone, releasing hormone. So it's basically a stimulator. It's a chemical stimulator. And then there's the testes and the adrenals, and those are the factories. So that's what produces the testosterone. So this hypothalamus in the brain, it's acting as a monitor. So it's kind of I think of it as a filter. It's just capturing all the testosterone in the system, and it's monitoring it, making sure there's a good level of an adequate level. So it's an overseer. If the testosterone levels are too low, the hypothalamus then tells the pituitary gland to get active and to pass on the message to the testes and the adrenals to start producing. So the pituitary gland is the messenger. It's telling everybody, get to work, start the production process. So that's kind of, when everything is balanced, that's how it's working. And we know that with testosterone, the levels in the body will decline with age. It's at its highest around puberty or young adulthood, around 25 years of age. And with each year, it has that potential to drop off and decline. So let's talk ADT, now that we've got the testosterone covered. So ADT, Androgen Deprivation Therapy, big mouthful, I'm not going to say that every time. We call it ADT. It's currently offered as a systemic therapy, so it's an injection, you get a needle, and it affects the whole body, which is why it causes a variety of side effects. It's given at regular intervals, and it depends when it's used and what it's used for. but it can be every 1 month, every 3 months, or 6 months, or even further apart. So it all depends, and that's a conversation that you would have with your physician about why you're getting it, say every 6 months. And it can be given for a short time or for a very long time. So again, you're all unique, and you all, if you are on it or have been on it, you know, there's a reason to be on it, and that will dictate the length of the treatment. So it is sometimes referred to as chemical castration, which isn't a great thought, but the rationale for that is that it's now chemical because before, around the 1960s, it was actually a physical castration. So there was a physician who discovered that this was effective by removing surgically the testes, which would then cause the same chain of events. It would stop the testosterone production and relieve a lot of pain for metastatic patients who were having a lot of bone pain. So now we don't have to go there as first-line treatment because that's irreversible. Now there's a medication instead. So there are 3 types of hormone therapy. The first type is the surgical castration. I just mentioned that. And then there are 2 different types, and these are the 2 we'll focus on tonight. They work very differently. They're doing the same thing, essentially. They're both stopping the production of testosterone. One is an agonist, and one is an antagonist. So you'll notice the small print there. An agonist is a chemical that binds to a receptor and activates that receptor to produce a response, a biological response. And the agonist causes an action, but the antagonist blocks that action. So I wanted to specify the differences there. And it is used, as we mentioned, to block the production of testosterone in the body, because testosterone is what's allowing the prostate cancer to grow, to proliferate. So it's fairly effective in its use. It's used in a couple different settings. The neoadjuvant is therapy before a primary treatment, and typically at this time, neoadjuvant would include hormone therapy before radiation, and it's typically 3 months, 6 months, 9 months, depending how quick it can effectively bring down one's PSA and shrink the prostate. So this is when I mentioned the time frame. Men can be on hormone therapy for just 3 months, or potentially 6 months, or a little bit longer, depending how sensitive their bodies are to the therapy. That will then indicate when they can stop that and start with radiation therapy. So neoadjuvant is prior to treatment. Then adjuvant therapy is typically given after a primary treatment has already occurred. So primary treatment would be the radiation or the prostatectomy. So adjuvant therapy would be the beginning of hormone therapy after, and it could be a couple months after, a couple years after, totally depending on everyone's situation. And then there's hormone therapy for metastatic disease. And this is used when one is not a candidate for radiation or surgery, and it's to stop the spread of any metastases. And this one can be used continuously or intermittently. So intermittent hormone therapy is when one has an injection and then they have another injection, say 4 months later, or 6 months later, or even a year later. So it's not the continuous injection. It's a little bit, you drag the time frame out a little bit. And that sometimes allows the body to just not build up a resistance to the medication. It allows for that full effectiveness to happen every time. And this medication is always prescribed by a urologist or an oncologist. I've never heard of GPs prescribing it before, but it could happen. How does it work? So let's talk about the agonist first. So one would have the injection, and that medication is mimicking the signal from the hypothalamus to the pituitary gland. So it's basically turning this on, saying produce, 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 go, go, go. And what this is doing is it's overstimulating or leading to exhaustion of that whole system. And it's kind of, I always think of it as, you know, you're so hungry and you eat and you eat and you eat. And then all of a sudden you're like, holy smokes, I am full. I cannot handle anymore. So that's how I wrap my brain around this brain and what's happening there. And when that does happen, when that overexhaustion happens, the whole axis shuts down. So the testosterone production halts, and you see a huge drop in that level. And then the PSA will drop as well. So the pros to this medication, that's the antagonist, sorry, the agonist. Oh, and I didn't mention, the medications that you probably have heard of are the Lupron and the Zoladex. Those are probably the two most commonly seen medications, and they are the agonist. So it's we call it a deephole injection because you get the injection and it stays in your body for that whole 3 months. So it releases slowly. And it's given either intramuscularly or subcutaneously. For those of you who've had the Zoladex, you know it's a big needle, it's a pellet, it goes in your stomach. It's not necessarily the most comfortable to have, but it's quite effective. And there are a couple options to choose from. So if for whatever reason you have, say, the Lupron and you have a skin reaction, or you get hives all over your body, or some really weird, unusual symptom, you could let your doctor know for sure and have that medication changed. The cons of this medication are that there is that initial surge in testosterone. So there's, because that whole axis is turned on, so it's producing all this testosterone. And if one has metastatic disease, that can lead to a rapid progression. However, there are medications that will block that surge. So the bicalutamide, nilutamide, or flutamide they're all medications that do the same thing. They basically just block that whole surge. And they're used for about 21 days or 3 weeks. And often men will be prescribed those before they start their hormone therapy. And it effectively creates a safe environment for that whole axis to get going. And the antagonist. So this medication is called Degerylex, and this is not given as often. And I'll speak about why in a second. But this is the one that has an immediate reduction in testosterone. So it doesn't turn on that whole axis. It just stops everything in its tracks and shuts it down. So the hypothalamus is not able to stimulate the pituitary gland. And then thus the testes aren't able to produce that testosterone. The reason this one is used is that it's beneficial for patients with metastatic disease because it doesn't create that spike in testosterone. So there isn't the risk that progression could happen. And it's also more safe for someone who has pre-existing cardiac conditions. So if that is the case and you are told you need to start on hormone therapy, your physician needs to be aware of that. So it's the safe one. The downfall of this one is that it's a monthly injection. So it's more high maintenance. You have to see somebody every month and get poked. And there's typically a loading dose. And I've heard from a lot of fellas that the loading dose can be quite uncomfortable. It feels like you've done 1,000 sit-ups and your abs are just super sore. So it's basically a loading dose, a big amount of the medication initially just to get the body to shut that whole system down, and then you would continue on with a lower dose for each monthly injection. So now we're going to talk about all the fun side effects that come with this. And the big point that I would like to highlight is that all of these side effects are the result of the testosterone being suppressed, not necessarily the injection itself. So I did mention, you know, if you have smaller rashes or you know, injection issues, we could change medications, but if any of the following side effects are happening, those are a result of having lower testosterone. So because it's responsible for so many functions in the body, so many systems are affected. So 80% of patients do report some degree of side effects. So that's a fairly high amount. And it doesn't matter if you've been on the nice list for the whole year, it might still be something you need to contend with. So, because it's December, I've included a little Santa edition here, and he's a really good example of, you know, to me when I look at him I think, yeah, that guy probably is on ADT, because there's a lot of things happening for this fella that could indicate maybe he's on hormone therapy. Not to judge, but you never know. So when you speak with your physician and that person says, you know, I think it's time to start hormone therapy, you know, and this is why, and this is the reason we need to do it, that person might just tell you a couple little side effects, and you know, it's a busy appointment, so they don't have time to go into all the minutia, all the tiny little details. So they're going to tell you the top 3. And you know, maybe it's a nice story, maybe it's not. They're not exciting side effects to consider. But hot flashes are probably the side effect I hear the most about. And they can vary. They can, you know, some men don't get them at all. Some men are not flat with them. I remember meeting one fellow when I worked in Winnipeg at a prostate clinic. He came in for assessment, and he had a very advanced disease. But he came in, and he was having a hot flash as he was talking to me. He was dripping, and he was red, and he was prepared for it. He had all his hankies and everything. And I asked him about this. I said, you know, these are pretty severe for you. Does your doctor know? And he laughed at me. He's like, oh yeah. He's like, I get these about every 15 minutes, and they lay me flat. And this was the way he just his life, and it was really frustrating for him. So I've never seen that since, but it was a really pronounced situation for this fellow, and it did not look like fun. So they do exist to a varying degree for everyone. For some it's trivial, for some it's so overwhelming. And some ways to avoid those hot flashes are avoiding spicy foods, caffeine, alcohol, and stress. Stress is the big one, and I think stress is something we should all avoid all the time. It's almost impossible to, but it's, you know, stress does some really funny things to the body. Avoiding hot climates can also help with that. I know a few fellas that I had conversations with this summer, the hot summer, and there were a few fellas who were having a tough time with their hormone therapy this summer. So it's a tricky one, and there's no magic pill. There's no easy way out of this one. There are medications such as gabapentin and Effexor that can be effective to reduce the symptoms. They won't take care of them completely. They won't leave you without hot flashes, but they will help minimize them. So if you want to go that route, that's definitely an option. But I've got another suggestion, and this is something that you'll hear me build into all of these side effects, is that the best medicine is actually exercise. We know that, and I bet all of you who are in the exercise group can, you know, can agree that exercise helps with everything, especially the hot flashes. Following a regular exercise regime can really help the body kind of acclimatize to what's going on and deal with all of the changes that much easier. Erectile dysfunction is another side effect of the hormone therapy. And again, there's no magic pill for this one. It's simply a result of the testosterone being suppressed. Testosterone is one of the main hormones required for erectile function. So when it's lacking, so is a response potentially. Not necessarily all the time, but it's one of those side effects. So I mentioned I am part of the sexual rehabilitation module, and we talk about ways to deal with this. I'm not going to go into all that detail tonight, but if you wanted to focus more on that, again, there's a pamphlet at the back, and it's an opportunity to investigate this a little further. And then paired with that, is the issues with changes to one's sex drive or libido. And again, it's strictly because the testosterone is becoming less and less. And as mentioned, with age it becomes less and less. And then you compound the hormone therapy to that, and potentially, fatigue from primary treatment or, life, stress, and it has an effect. So again, exercise can, we know, help with that. Exercise, gets all the good hormones in the body moving, and it helps, just make one feel good, motivated, potentially increasing one's libido. So you might notice some pretty upsetting side effects as well. So we talked about what the doctor might tell you, and then what you might notice when you're, in the first couple months of this. Some changes might be noted, maybe not. I've heard a few fellas tell me that, this was no big deal. They just breezed through it. They didn't notice necessarily any weight gain. But we do know that about 40% of men are overweight at the time of diagnosis. And then once started on hormone therapy, it's common to gain about 20 pounds potentially. So that's, I think, on the higher side. I wouldn't say that's typical necessarily, but that is a potential. And that's typically over 6 to 9 months is when that weight gain would be noted. And the weight gain is noticed at the waist. It's both external but internal as well. And we know, I think a few months ago we had a speaker who talked about visceral fat and how incredibly dangerous that can be to our heart function, our liver, our lungs, everything. So, if you're gaining weight on the outside, it could also mean that there's weight or adipose tissue stacking up on the inside. So we don't want to go there necessarily. And with that weight gain, there can be this loss of muscle. We know that, testosterone, when you Google testosterone, the first thing that comes up is all these photos of bodybuilders and all this muscle, right? So we know that the reduction of testosterone also reduces that muscle. So it's, again, a double whammy and not a comfortable place to be. Hair changes can be noticed, and that's not typically the hair on the head, but maybe beards become softer, body hair might become thinner, and some changes to body composition. So gynecomastia is the whole concept of increased breast tissue, and that can be bothersome for some folks. And then penile or testicle shrinkage as well is a potential. It's reversible when treatment stopped, and again, the tissue change is due to a decrease in testosterone. So when ADT is stopped, then things will regenerate. And again, there are ways around that while on hormone therapy, and we can talk about that in the sexual rehabilitation course. So what you may not notice, what might be happening in your body, that is, you know, these are the big red flags for us, and this is hopefully what your physicians are monitoring with all your lab work and, you know, your assessments. There's this, I think of it as a Bermuda Triangle, this metabolic syndrome. It's a triplet. It's a combination of hypertension, of progression towards diabetes, and cardiac issues. And this is due to increased body and visceral fat, or that adipose tissue. And this basically increases your blood pressure. It increases the cholesterol and triglycerides in your body. And it increases your insulin resistance. Your body isn't able to use the insulin as it normally would. So this metabolic syndrome is something to be concerned with. But again, if your weight is staying the same, if you're active, if your diet is in good shape, hopefully this is completely avoidable. Anemia is another concern. And the reason for that is because with hormone therapy there is some bone marrow suppression, and we need that bone marrow to produce all the good red blood cells. Red blood cells feed your tissue all the nutrients, all the oxygen, so you need that. And you know, thinking about ways to get around that are looking at diet, and you know, maybe we could talk about that in one of our hot topics conversations. How to boost your red blood cells. But you would notice anemia if your muscles are always tired, you're short of breath, you're tired all around. That, and maybe you're pale. Anemia can really lead to a lot of fatigue. So it can be noticeable, but not necessarily so. It's picked up on a CBC or lab work. So the last thing I want to point out here is the bone density loss, and that's something you might not notice, but it's quite concerning, especially when paired with increased weight gain and potentially decreased musculature. So we know that men on ADT, they're known to lose bone mass almost 5 times that of fellows who aren't. And they are then twice as high at risk of having a fracture in comparison with men who aren't on hormone therapy. So it's really important to supplement with calcium and vitamin D. That's a very common recommendation by most physicians, most dietitians. And potentially having a bone density scan prior to treatment, maybe, if it's a treatment that you're on for a long time, maybe a year after. Again, that's something to have a conversation with your physician about. But bone density is a very important thing, and something that can be maintained through the use of exercise, weight-bearing exercise, resistance exercise. So anything where you're working against gravity, climbing stairs, going for a walk, using resistance bands, doing push-ups. I'm sure Paul can demonstrate all sorts of resistance exercises, but they're really important to maintain good bone health. So I cannot stress that enough. Run out and talk to your doctors about that tomorrow if you'd like, but it's an important thing to consider. And then, with all of this, you might not be feeling really fatigue. Fatigue is one thing that I hear probably more commonly than anything. It's, and what's it caused by? Is it chicken and egg syndrome, where, you just finished a treatment of sorts and you're wiped out? Are you anemic? What's causing that fatigue? It's one of the worst and probably the most preventable side effect. And again, I bet you can all guess what I will recommend to prevent it, and that's exercise. It's really hard some days to motivate yourself to get up and get out, especially when it's rainy and it's cold like it has been. But once you get out, you feel, you get the blood moving, and I think most of us feel pretty good, and you gain energy that way. It doesn't have to be, 10 kilometers. It can be just going around the block, getting some fresh air, getting everything moving. That's the best way to combat the fatigue, because there's no medication, and medications aren't going to solve all of these problems by any means. And then depression, or I kind of like the idea that it's more an emotional fragility potentially, moods that maybe fluctuate. If you are prone to depression, that can be compounded by the hormone therapy. But it's maybe more just being sensitive. Maybe shedding some tears in a really sappy movie or something. Just being a little bit more sensitive. And then this whole concept of cognitive dysfunction. And it's not, dysfunction sounds rather harsh, but I think it's more just spatial memory issues, like, oh boy, where did I park my car? Or where did I put my keys? Little memory games like that. And, is that, again, because of the fatigue? Is it the medication? What's causing that? But does it matter? I think it's important to realize that, yes, it's a potential, but how do I work around that? What do I do to minimize that? And yes, exercise is great, gets everything moving. But I think, things like reducing clutter around the house can make things easier, or in the car. Having a look at your medications, and maybe seeing your pharmacist and saying, your pharmacist and your family physician, and kind of going through everything and saying, are these all necessary? Because we know that, medications can affect, they can create symptoms and side effects. So if we can just minimize in life, I think that would be a really good mechanism here to cope with that. And then reducing suppressants like alcohol and other depressants is a really good way to cope with that cognitive dysfunction. So, exercise, so important, and I can't highlight that enough. We have a really good exercise group, and I hear great things about how these fellows are feeling all the time, and I think there's huge benefit to that, whether you do it by yourself, with a partner, with a group of people, whatever and however you want. It will really help with all of these side effects. And the amount of exercise is kind of important as well, and the prescribed amount of exercise is 150 minutes per week of moderate to vigorous activity, and moderate to vigorous falls between the 4 and the 7 numbers. So basically, you're working, you're getting warm, you're starting to glow a little bit. You can still carry a conversation, you're not totally out of breath, but it's kind of getting borderline uncomfortable and maybe not sustainable for too long. So a little take-home message there. And, the best way to minimize and take charge of your own situation is to be an active participant. To really look at your exercise regime, look at your diet, the foods you eat and how you eat them. Peer support can be a really great opportunity, as I'm sure you're all invested in that. And just talking about these things with each other and trading notes and seeing what's helped for your friend. Involving your partner is huge, and having those conversations. Let them know where you are and what's an issue for you. Pelvic floor rehab is another another consideration, we didn't really talk about that a whole lot tonight, but again, with, you know, just the anatomy and all the changes happening there, pelvic floor rehab can be another way to, you know, help with any urinary incontinence and help with the erectile function as well. So again, it's another avenue that I'm happy to help you steer towards. So if you need any extra info about that, I'm happy to help. The sexual rehabilitation piece is important if it's something you're wanting to look at. Counseling to talk about any of the emotional weight is always an option, and I can help you with that as well. We have some options there. And then speaking with your healthcare team, so keeping your urologist, your GP in the loop. I'm happy to sit down and go through anything, you know, one-on-one. And, you know, I think anyone you come into contact with would be happy to help in the healthcare network. And so that is ADT, my friends. Do you have any questions about anything that came up? Yes?
What would be the percentage of men with prostate cancer that would be prescribed AD therapy?
That's a good question. I don't know if you all heard that, but it's a question about how many men, or a percentage of men would be prescribed hormone therapy. And I guess that depends. I'm not you know, an expert on the stats. I think a urologist would probably have more stats around that, but anybody who is looking at radiation therapy, it's almost a guarantee that you will start on the hormone therapy. And anyone who has a recurrence later on will likely look at hormone therapy. So, you know, it is a common thing. It is a common therapy that most men, once they have a treatable prostate cancer diagnosis, they will have to consider that at some point along their journey. I don't know numbers, but I can ask around and get back to you on that. Yes?
How long does it take to work itself out of your system?
Good question. I've had a radiation oncologist advise that as long as you're on it, it takes that same amount of time for your system to get rid of it. So if you're on it for 6 months, 6 months after you're finished with the hormone therapy, it should be out of your system and your body should be returning back to normal. It's normal function. Yeah. Any other questions? Okay, well thank you. Oh, yes, in the back.
I'd like to say when I got the ADT, I have pictures on my camera, and I've got bruises like that, really, you know. And they gave me 3 injections at once, one on each side and one in the stomach, and you can't really bend or anything for a while. And I also found out that they give you, as you said, tablets at first, and then when they give you the ADT, there's no guarantee that it will push down the testosterone, because mine went rocketing down, and I thought, great. Next injection, it just went the other way. So it's not an easy, like, oh yeah, just get a few injections. And they were telling me it would take as long as 14 to 18 months to get your testosterone down.
Oh, okay. And I guess everybody's so individual, right?
Yeah, it's different.
Yeah. And I think the medications aren't all created equally necessarily for each individual. What works for you might not work for me, and vice versa. So it's finding the right one sometimes.
I wasn't prepared for the night sweats. They were, the easiest way is you've stood under a shower and you're wringing wet from the top of your head right the way down.
Yeah.
And it woke me up because the sweat that was drying was going cold. The duvet, the pillowcase, the bottom, it was ringing. Nobody told me. They just said, oh, you might become a little bit uncomfortable.
Yeah.
Yeah.
And again, it's that communication initially, right? When you start that treatment, it's really, it would be so valuable if you could
Yeah.
come away with, you know, a package or an information session where it's all laid out for you and you're made aware of all that and how to manage that too.
What I liked at the cancer clinic was when that figure shot up on the blood test, that he said to me, don't worry, I've got a plethora of the medications that I can give you. And like I said, it did work eventually. And everything you put up about fatigue, sweat, everything,
Yeah.
I got it.
Yeah.
Yeah.
And one thing I've heard, and I actually, as I was kind of revising this before tonight, was sleeplessness. I forgot to put that on there, but that's a big one for a lot of fellas, is, you know, the inability to sleep well or have the same quality of sleep that they had prior to treatment. And is that linked to night sweats? I'm not sure, but it's another big concern as well. And then that affects one's fatigue levels during the day, or energy levels during the day, and motivation, and et cetera, et cetera.
I'm not making light of it, but when it woke me up, my first thought was, I've got a water pipe in the ceiling, it's burst. That is, yeah, that is the extent of what it was. I was wringing wet through, right the way down to my knees. You know, I mean,
Yeah.
it can do a big number on you.
Yeah. Not comfortable.
Well, I never had it before, so.
Thanks for sharing. Thank you.
So I want to thank Connie. I think this has been a really important session because one of the things that I've learned from coming to these meetings for a number of years is the number of men who've told us through questions, the things that they've asked and they've contributed, is they didn't know what they were getting into with ADT. They didn't know a lot of these things were going to happen to them. So all these things here aren't going to happen to all of you. Some of them may happen. Every one of our journeys in prostate cancer is very individual to us as individuals. So don't be frightened by everything you've heard, but it's being aware of the possibilities that are out there, and you've heard some of the ways to deal with it. There are ways to manage these things. So I really want to thank you because I think it's been a fabulous session.
Thank you. Thank you.